Come. So, what is the sound alike is the met. The metformin and metromidazole. Correct. Give me another. And the sunlight is a two. And close. Is somebody still writing or still thinking? Can we go ahead? You're 5 minutes almost exhausted. Tell me.
Carboplatin and cisplatin look alike and sound alike.
So do not forget, because you are not going to be remembering. Yes, my dear. Now, when you have a LASA, if you have just one, take your phone and check. There's a new one. That one wants to. Yes, check, refresh, and you'll see a new one. When you have just one in your phone, in your list, is it still considered a LASA?
No.
Of course. When you have one, it's not a LASA. It's just another medication. It becomes LASA if you have two of them in the same medication list. Is that understood?
Yes.
Now, if we give from LASA, which other type of medication are we looking at? A fall-risk medication. The next medication you'll be looking at is a fall-risk medication. You will actually check on the fall-risk medication and you count them to be 1, 2, or 3. But when you start doing your interdisciplinary form and you will be going to be filling and saying 2, there will be somewhere you go and put 4. And then you will forget why there was a 2 before. So when we come to check for that month, I'm going to ask you, why are you now putting 4 here? You are going to be confused. Because you did not put it in your head that the reason why there was a 2 on the fall-risk is because of the number of fall-risk medication that you have. So you should have the list of fall-risk medication. Do you have them?
Yes.
Correct. So when you start duty, you should check your medications to see the number or the number of fall-risk medications that are in your keeping. Is that understood? And except another 4 weeks medication has been added, it will be the same. So you do not add or reduce when you do not know why you're adding and why you're reducing. Is that understood? Okay, so we have taken the 3 hearts out. We have gotten it right up to this level. When we leave 4 weeks medication, which other sequence are we following? High frequency to the lowest frequency. And when we talk about high frequency to the lowest frequency, what are we looking at here? QID, DID, TID, BID. It is never OD. What did I say? Weekly, monthly. It is never OD. I should never check your PMIs and I see you write somewhere OD. Is that understood? Because according to medicine, in its abbreviation, OD stands for a lot of things, and those things, once daily is not one of them. So you must spell it out once daily. So this will be the frequency in which you are going to present the medication. And we are going to be looking lastly the PRNs. When we have put our ODs here, if you are taking consideration of the paper, when you have listed them all in order, what next are you going to? When you listed them all in order, what next are you to do? I will take this off to represent the PMI here. So we have the medication, med, we have the dose, we have the frequency, we have the route, we have the time, we have the date here, which is morning and night. Okay. So we have represented our medication using LASA, using high alert, LASA, fall medication, and we have listed them per frequency right down to the PMR, the PRN. Now take into consideration, you will never write a PRN before a standard medication. Even if that medication is once yearly. Do you understand? As long it has been put as the standard medication, it must be put before a PRN. What happens if the medication that is PRN becomes frequent? What happens? What do you do when a medication that is initially PRN is now frequent?
We arrange based on the frequency that is ordered for the next form.
Explain it.
Example, if you already fill out the form with the proper arrangement, then there is a new order. Put the medication, hold, then highlight. Then in the next form, after the date was consumed, you will arrange again the medication
As the order.
Yeah. As
Okay.
per order.
Now this is not what you are now talking with regards to a new order, but I am talking about a PRN, a medication that was administered. Let's say it was given for pain, just when it's necessary. But now it becomes too necessary. You will start administering it often, 3 times per day, 4 times per day. But initially it was given just per PRN. How do you solve that problem? How do you intervene in this situation?
Uh, you still need to fill out, the order is still PRN, but for example, for the Sineticon, it's because the patient is having bloated.
Mhm.
So until the patient is not relieved, so you need to fill out still the in the PRN.
You would fill out, yes. My still question is, if a medication is PRN, and now you realize that for the past 1 month, I have been giving it too frequent per day, per week, what is your intervention?
It's a medication that takes over and
It's not a medication error.
Refer to the doctor.
Clap for her. The medication is PRN, okay? Given only when it's necessary. The necessity for this medication has increased. That means there is a concern. Instead of making it PRN, we need to make it a standard medication. And for you to make it a standard medication, you need to call the physician. You will call the physician, you will explain to the physician what is going on, and that this medication was administered as PRN, was prescribed as PRN. Now I'm giving it 3 times a day, and it's been 1 month, and it's been 2 weeks, it's been 3 weeks, it's been 1 week. I see that the medication has become necessary for it to be removed from a PRN to a standard. The physician will re-evaluate. They might send a medical team to the house. They might take blood tests for examination. They will evaluate everything all together. If it is necessary for him to make that medication a standard medication, it will be changed from a PRN to a standard medication. Is that understood? Take this very carefully, because this might be one of the questions given to you during your exams. And if this question is posed to you on a frequency of a PRN, and you say you have never heard of it, voila, I will not be happy with you, because you just heard of it. Is that understood? It is a problem that needs to be solved. If the patient has been in pain for a long time, as frequent as 1 week, 1 month, there is a need for reassessment of this patient. And there is a need for a constant or a standardized prescription given with regards to that pain. So you will definitely need to get to the physician. You will need a medical team to reassess the patient, and then they can change that medication from PRN to standard. Is that understood? Okay, so let's leave the assessment and leave every other thing. Now we are going to the medication, and we have finished the frequency of the medication. When you write a medication that is PRN on the medication list, you must indicate the PRN. Don't forget. And the reason why there is a line under PRN is so that you should give the purpose. Do not indicate PRN and not write the purpose. Is it for pain? Is it for constipation? Is it for relief of congestion? A nebulizer? You should indicate the reason. Okay, now if we leave from here saying that if you look, the first thing after the medication, you have the medication order. What are you writing here? Miriam, say something. What are you writing there? The day, the order date. Now, what is the order date?
when the medication was prescribed.
Exactly. The other date will be the when the medication was prescribed. Now, when you take your medication list, you will see the other date on the side of that medication. You will write it. If the medication is ordered during when you started duty, you equally write that day to be the day that the medication was ordered. Is that understood? Now, when you go from there, you see commencement date. What are you writing for commencement date? Stroke time. Thank you. When you started that medication, not when the medication was started by the family. So if you start duty on the 5th, your commencement day is the 5th. If that is the day you administer that medication. Now let's say that you have one medication that was given 2 weeks and you started duty, the medication, you did not administer the medication. And you are not administering the medication within 2 weeks' time, because when you came, the medication was given, right? Your commencement date for that medication will be that day, in 2 weeks' time. It will not still be the same day you started duty. Is that understood?
Yes.
Now, when we leave the commencement date, we are going to this continuation. You write the date and the time, because when this will be very important when you are using LASA or eye drops or ear drops, medication that their lifespan has a short cycle. Is that understood?
Yes.
What is the lifespan for a pen, an insulin pen? What is the lifespan for you opening an eye drop or an ear drop? Correct. So you know that you must hold that medication on the 28th day. That pen will be finished. Even if the medication is still inside, you must discard. You will know that the eye drop or the ear drop, even if it is still in, on the 28th day, it will be finished. And the 28th day, when you should stop, will determine when you started. Will be depending on when you started. Is that understood? Okay. So the discontinuation date, it is equally going to regard when we talk about tablets. You will see that some tablet antibiotics that are prescribed for 7 days, or for 10 days, or for 12 days, or for 1 week, or for 5 days, they will tell you discontinuation date is this day. How do you discontinue the medication? You have to highlight the medication that you have discontinued and you go to the last day. If you administer the medication today, it was administered by me, Aisha. When am I supposed to cross?
Next week.
The next day. And you are crossing from which direction to which direction? From the far up to you. So you are crossing like this. Is that correct?
It's not.
Don't make an error. Do you get it? This is why the same class is given to you 2 times. And we will give again 3 times, and then 4 times. Because there is a lot of classes, and those classes you should not forget them. Okay. Now let's go to the next one. From there, we have talked about PMR, PRN, medication and their indication. Now we are done with this. Is there any question regarding how to fill medication? Anything you did not understand? You do now. Is there anything that you think you are lacking when it comes to just filling this one column? Janelle, is this okay by you? Well understood? Asaria, do you understand everything what I have said here? Any question at all? Mary? Kafana? Okay? All right. Now we are completely done with this. We are completely done with all the steps that necessitate you to fill this column correctly. Let's go to the dosage. Now, when we are talking about dosage, what do you look at? The prescribed dosage. It is 5 milligrams, it is 10 milligrams, it is 5 international unit or 2 international unit, it is 2 drops, it is 2 tablets or 1 tablet. Now, you would have put tablet, but what happens if the tablet is 2? You will write it 2 tablets. Because we are not seeing anywhere else where we are going to indicate that this tablet is 2. If you write only tablet, it means that it's 1 tablet. And you will look all through, there will be nowhere where you put or 1 or 3. So if you did not include these 2, indicating that your tablet is 2, or half, indicating that your tablet is half, you are always going to give 1 tablet, which is wrong. Or maybe you already know that it's 2 tablets, so it's okay. But what happens if I send another nurse? Do you think you are going to remember to tell the nurse that here is 2 tablets and not just 1 tablet? So you have to put 2 tablets. Okay, is this aspect understood? This is easy. So we are done with this. Where did I keep the pen? So, correct. This is finished. Now let's go to the frequency. What are the frequencies? The frequencies, we have QID as per, as long you're done with LASA, high alert and forex. You start going to QID, TIDs, right up to the PRN medication. This is okay. Now, we go now to what? To the route or to the root, depending on where you're coming from. We have the legends that are used on those positions. Give me the first legend.
PO for orange.
Yes, continue. Continue. IV. Intravenous, yes. Kapano, take over. Subcutaneous. Exactly. Now you have seen the different legends that are given there. When you have any of this medication, you will just circle the legend. Are we correct here? You circle that particular legend. Now, this column, you, as you are looking at me, you will not feel it. You are going to feel everything and then allow this column for me to come and feel it. Or for me to come and raise my blood pressure before you feel it. So today, indicate on your rough papers, it is a must, remember. Because when you have 15 medications, you are going to fill in everything, and then when you come to this one, you allow it. So you should remember to fill it. And when there is a legend that is not on top of this thing, what do you write? You will write it on others. Now, you will not just go to say topic. You will not just go to say eye drop. You must circle others before you write the others. For those that will be too kind, they will come and write topical. They will write eye drop. But you know what they will not do? They will not circle others. And they will still be in square one. Why did you not circle it? There is nothing here that is for luxury. There is nothing here that is a PRN. You do it when you like. Everything here is a must. It Is that understood?
Yes, ma'am.
Do you have any question in regards to this? Now, do I still need to tell you how to sign per date, time? If it's a PR, if it's you are an RN, the site or the remarks? Do I need to tell you all about that again? Correct. Is there any question that you want to know about your medical record form? Is this understood?
Yes,
So Ma'am Ira has taken you and I have reminded you again because this is your last class. There is no other teaching you are going to get. After you finish today, you'll be going to shadow tomorrow. After shadow, you come back to take 2-3 days in the simulation room, and then you have your exams and you go to duty. No more teaching. So no time to forget. The only thing we are coming to do is audit. That is just it. You are either doing the right thing or you are doing the wrong thing. You were taught. Is that understood? Okay. Now let's keep our PMRs out of it. Let's keep this one nicely. I will take it back after I will not put something in it. All right. So if we are done with this one, bring out your nurse's note. Give me one paper out of the nurse's note. Okay. Take out your lesson. No, the next one we are going to be okay. Somebody tell me how you are supposed to fill your nurse's note. Kapana, start. Buvana, start.
First put patient sticker
Yes,
and write the date,
yes.
fully 2025. Date, the day,
The
month,
day, the month, and the
and
year. Correct.
and time, military time, like
The nursing time. And the nursing time is the French time. Is that correct?
Yes.
Okay. Yes.
and the special notation is if patient at, admission,
Mhm.
then need to write admission note.
Now, what is the first notation that you should take? Because now, when you're talking about patient's admission, this is an occurrence that will happen when you started duty already. But what is the day-to-day thing that you'll be doing? I'm listening.
Next one, nurses notes, write patient admitted on admitted year, age, and name, Qatari patient, nursing provision of diagnosis, next diagnosis,
Okay, there's something.
So she was telling that when we are starting duty first note, will write that.
writing full.
Like patient details, we will write.
Okay. This is on the first duty day.
Yes.
Okay. After. Take me after.
After receiving notes now,
Mm-hmm.
receiving notes and write notes, patient age and
is she fidgeting? Don't fidget. Just talk to me.
Patient conscious or oriented.
No, I don't want the details. I want just the notation.
Interdisciplinary plan.
They
God knows that I don't understand what you're talking about.
daily notes.
Your daily notes, your daily nursing notes. Let's forget about the first day of admission. What are your regular nurses notes that you are going to be making? This is what I want to know. Yes,
First, we will tell receiving notes,
receiving notes. Yes.
then care partner, plan care program, or health education.
Your daily, for example,
Yes.
First is receiving notes, then vital signs,
Uh,
check notes,
uh-huh.
then patient. And then if we are telling the care partner wishes, that's also we can mention. Care partner wishes. We are educating the care partner. What
Atelier, tell me what you know. What do you know?
First receiving note, then vitals, then any special special note for given in the health education.
Mm-hmm.
Okay, any special problems means pain or
Mm-hmm. From there.
medicine.
medication administration also we mention. If patient refused.
Special is still under special notations of what happened. Yes. What else? Mira, you have anything to add? That is still the same ideology you have.
If emergency visit is there, that also we can mention in the nurses notes.
Yes.
Any physician, any other visits, this also.
Okay. Tell me. What do you know?
Notes. At last handle notes.
Hand over notes. Okay. Tell me what do you want to say?
I just want to explain how I know.
Hand over notes. Okay. So yes, gradually you came all together to list the things that you put under special notation. Now for special notation, when we look at our nurse's note, we have the date, we have the timing, we will have the special notation, we will have the nurse's note itself and signature. Okay? So we have filled this, now we have a problem with special notation. With our regular special notation, it will start with what? Receive. It will start with you receiving the patient. And in between you receiving the patient will be something that happened on duty that is not in its normal regulations to happen. Number one, in case patient's BP was high, temperature is high, sugar is high. So after checking the temperature or the vitals, you have a vital sign sheet to fill. So if everything is normal, do you need to write vitals here? No. But if there was one of the vitals that is high or is low, you will now come to make the special notation vital signs. You will indicate what went wrong with the vital signs and which vitals in particular is wrong. If you had a visit from the hospital, HMC visited you, you are going to indicate the visit and you write it. If you have an appointment in the hospital, you write the appointment and you indicate what happened during that appointment. If you call the doctor for one reason, or the doctor called you for one reason, you will indicate. Now, these scenarios are the unexpected things that happen with you on your shift, not the regular things that have been happening. When you leave this, the next thing you should be writing is what? The next thing you should be writing is handover. So if everything is normal, nothing changed, patient is okay, no change in mood, temperature, fish, nothing, I should say receive and hand over. When you receive the patient and when you hand over the patient, you are receiving the patient with patient is alive, dead, or vegetative. Patient was seated, patient was in the room, patient was in the toilet, patient is this. I need you to tell me how you receive the patient. Is that understood?
Yes.
Do not take over a shift with a patient that is not active or alive. Are we communicating?
Yes.
And you must hand over shift telling us how you handed over the shift. You handed over the shift with the patient sleeping, or you handed over the shift with the patient eating, or you handed over the shift with the patient and to cook. You took ownership from care partner and you're giving it to the care partner, or you took ownership from the family and you're giving it to the family, or you took ownership from another nurse and you're handing over to the nurse. And was it with family or without family? Especially when it comes to handing ownership. Are we together? When you are done, you will sign. Now on your nurse's note, there should be no gap left anywhere. So if after writing, I should sign here. And when I start again, I should start from the next line and continue, not skip the position. Are we together?
Yes.
Do you understand?
Yes.
Okay. Don't say I did not say it. Tomorrow, I don't want to hear stories. As easy as it looks, you will have problems with it. Now, there should be no superimposition. Don't write BP and then you come back to write this on your PMI. Don't do it. Don't write the date 6 on the 7th, 2025, and then you come back to say, no, it's not 6, it's 9. Don't do it. The right way, if you must cancel 06 on the 09, 2025, and I realize I made an error. I put here instead of 2025, put 2026. I will put one stroke and I'll write 2025. And I will sign with my name. Now, must I write it like this? No. Why am I writing like this in space, in a condition where you don't have any space to continue? If I have space ahead of me, I should be writing 06, 09, 2025, and here there is an error. I put a stroke. And I signed with my name, I start with Inglewood, and I go ahead to write the right thing. Is that understood?
Yes. Yes.
But you can go up in case you don't have any ahead to first stroke. Are we together?
Yes.
Is this form, the revision of it, does it make any sense to you?
Yes.
Is there any question? right up to now. Uh, where is she? She's not come right up to now.
Maybe they are submitting the teach.
Does she has to be there? Can you find out? Because I need to take this endorsement. I have. Sorry, you don't have. If you want to eat yourself, you can go. You can take some water while we wait for the next. But immediately she comes in, you all come back to class. Daily endorsement. I am going to add all of you in the group, please remind me, let me not forget. I'm going to add all of you in the group now. That is for the endorsement for shadow. When you finish and you pass, you can now join the endorsement for the senior nurses. Okay? For the pediatric, you have a pediatric endorsement group, and for the adult, you have adult group. I don't want to join it all together, and maybe there's an occurrence someday and I'm trying to look at a particular report I cannot see. Are we together? Okay. So let's take it from your endorsement books are with you. You're done, Habibi?
We're just waiting for the email because they have is processing the transfer.
She's processing the transfer of sponsorship. The ID is already out.
It's with me.
You came with it.
Yeah.
Oh, congratulations. What happened that it was today?
I don't know, sir. That is the one who is talking to the,
With the people?
yeah, we go to MOI,
All right.
the pearl.
No problem. Just sit, let's get done with the endorsement so that I don't have to take you alone for endorsement class. Wait, seriously. So we are going to make this endorsement very fast, very easy, and we are going to be done with it. You read through. I asked you all to read. How many different types of reporting are there? Are you giving me, are you guessing or you're giving me the right one?
Three, admission report,
We have admission,
daily report, and
we have daily report. Somebody wants to gain.
No.
We have
nurses.
I'm listening. How many reports are there? There are how many types of reports? Did you read your endorsement? If you read it, how come you don't know the numbers or list the reports that are available? admission report, we have daily report, we have incident report, we have appointment report, we have end of life, which will still be under incident, or admission, appointment or admission. Is this admission the same as this admission? What is this admission talking about? Admission here is the first day you started duty. This is this admission. And this admission is applicable only once, and after once, it's not applicable. And this admission, what are you talking about? Patient in hospital. These are the different reports. So your daily report could be a daily stroke incident, or a daily stroke admission or appointment report. Or if it is an end of life report, it is an end of life report. Okay? With all of this, you read, but you did not see all of this in this endorsement book. It's not in the endorsement book. Are you saying it is or it is not? So how come you not see it? Because you are not even opening to the right positions where you are expected to see it. So how do you read? I know this class was going to be short, and that is why I needed you guys to study. Now, when we are looking at the admission, daily reporting, incident report, appointment, or end of life, they basically have the same starting. Okay? They basically start the same. And there is only a difference when it comes to presentation. Now, before we go to the admission report or to any other thing, what is the importance of doing your daily reports? Because remember, you have a nurse's note and you have a daily report. And then you nurses will start being confused of what is the nurse's note, what is the daily report. And that is why I started by giving you these differences. Your daily report, your nurse's note is with you. And what you are going to hand over to the next nurse. But your endorsement is with me. You are sending your endorsement to me. Your other nurse is sending her endorsement to me. Your endorsement will entail what you have done per hour, the different things you did across that day. But in your nurse's note, are you going to do all that? No, you're not putting all that in your nurse's note. So eventually, I am the one who has the report in case there is a scenario and you need to clarify your name. I will be the one to give that report. Because your nurse's note does not have a rundown of what you have been doing on that day. Are we together? So the only place you are going to have this information is in your endorsement. And that is why if there is a situation and maybe family calls HMC or family calls PNS and they need me to prove what happened, I need to go to your endorsement on that day and cut a message and send to them to read by themselves. Because that day you cannot change what happened on that day. You send, you send. You cannot edit it. If I have read and every other person has read, you cannot edit it again. And even if you edit, it will be written on edited. Is that correct? And that is why if your report has a problem, I will simply ask you to redo it, not to edit it. I don't want that to be changed. Give me 1 minute. sorry. Where was it? Okay. I was saying something before I was interrupted.
The edit.
Okay, we're looking at, yes. So I'm not going to ask you to edit. I'm going to ask you to redo it and send the second time. Because editing is compromising the authenticity of the first message. They will not know what you've edited, but it is indicated there it has been edited. Even if you edited by just correcting your own name, just the fact that it read edited is compromise. Is that understood? Okay. Now, what is the objective? When we start looking at the objective of why you must do your daily report, we are looking at what? To ensure that communication and continuation of care is accurate. Sometimes I might not read the daily report every day, but in a week I will find time to read. And when I'm reading, you know that I'm reading. If I've never read, you know I'm not reading, because each time I read, I put a thumbs up on the messages, and if I have a general message to make, I'll make. But if the end of the month where everywhere is choked with office work, I might not have time to go through the daily reporting. Okay? But I will see. You are to send your daily reporting every day. You are to read, in case you have any doubt, to read what she wrote for her daily report if you both are working with the same patient. So the accuracy and the continuation of care is what I want to see. It's what we want to be able to know exactly what she did, the rundown of all what she did the first day. Are we together? Next, we are equally going to be doing what? It is important to know that communication is key to success, especially when talking about nursing and handover. And that is why we keep saying speak. Speak. You need to talk, because you will be talking with the patient, with the family, with the care partner, with us, with the hospital, with the physicians, with specialists. You cannot afford to be timid. You cannot afford to be shy. You need to speak and be audible enough for the next person to hear what you say. Next, we'll be looking at what? Safe work environment. Because if the patient already sleeps by morning and fell, I want to know that you break the patient's leg before giving me the patient. So that when I'm cleaning the patient in the morning, I should be tender, careful, and show some empathy. If I come and the patient is agitating or irritated, I want to know that the patient was irritated in your shift and be able to care or approach with caution. If you had a whole shift because the patient visited the hospital and is agitated or irritated, and then I just come in, Mama, how are you today? How was your day? What do you think you should be doing? Like, are you okay? I should know. Because your hands up will help me to know how to approach and how to walk. Now, instead of me entering the house and looking like I just won the American lottery, I will enter with caution. Hello, Mama, how are you? How was your hospital today? Is everything okay? When Mama sees and hear and feel the empathy in my voice, it will make her feel like, you know what, I'm not exaggerating. I am equally just sick like every other person. My feelings are taken into consideration. Do you know when you are sad and somebody is jumping closer to you, you feel like you should shove that person in a pocket and keep the person there till when you start feeling better before you remove. But if that person approaches you like, well, you're having menstrual pain, I'm so sorry, do you mind taking something? Should I bring you water? I know you are considerate. I know you are trying to fit in my shoes. You are trying to feel my pain. So always help to make the environment safe, not just for yourself, for the patient, for your colleague, for the family, and for those that are around. Because sometimes even the patient will shoot at their own children. Is that understood? Okay. And And for the services, which services, nursery services do we render? After year,
24/7,
1,
12 hours.
12 by 6, 2, 12 by 7, 3,
24/6.
24 by 6. These are the different services that will be offered. Now, when we start with service number 1, which is 24/7, we are having 2 nurses with 1 reliever or 2 relievers. That means this is a battalion of people working on the same patient. And if we are 2 nurses, we will be working a morning, that is the day or the night shift. If we are working the day or the night shift, I will be putting 1 person for day and 1 person for night for that month, because I cannot change your shift as will within the month. When your shift is like this, the next month I will switch from here to here and here to here. If you are comfortable working only the night and your partner is comfortable working only the morning, you will send me an official email indicating that you want to maintain that shift until further notice, until the patient is, we discharge this patient. And if your colleague accepts, you send me the mail, I give it to sir approves it, I will send it back to you. You can work your shift. Why am I doing this? It's because a nurse will tell you, I want to work only night shift, and after 2 months or after 2 weeks, they tell you I have headache, I have nausea, I have vomiting, they have been keeping me for night shift for past 2 months. I did not say it, you requested. So I have proof to tell you this is what you signed and this is what you requested. But now, these 2 persons have the opportunity to get this switch. If you want to work day or you want to work night, after putting you on this month, I will change to the next one and you all can have the shift. But for somebody that is working 12/7 or 12/6, I'm sorry. If the patient wants you to work night, day, you work day. If the patient wants you to work night, you work night. I am not the one requesting or deciding which shift you should work. They are deciding which shift you should work depending on when they need a nurse. If they have a care partner that will work in the morning and they now need a nurse to work in the night, that is the shift you work. If you have headache, I will tell you I'm sorry. Get rest. If you have stomach, if you have sleepless problems, I will tell you I'm sorry. Find time and a cool environment to sleep. I cannot solve your problem. If you are sick, I will give you emergency leave. You go to the hospital, I'll send a reliever, and when you're back, you go back to the patient. Because you are the official primary nurse to that patient. Is that understood? The only person that will be dancing between shifts will be these 2, the relievers. And when I have 2 relievers, one reliever will be relieving only morning shifts, and the other reliever will be relieving only night shifts for a month, and they will change. Is that understood?
Yes, ma'am.
So please, if you happen to get a patient that wants only night shift, your day will be your night, and your night will be your day. If you have patient that wants only day shift, you will work a constant day and you will sleep at night. If the patient wants you to come at 6, you have to get up from bed at 5. Is that understood?
Yes.
The preparation starts from the mind. When your head and your mind is in accord with what is going on, you don't suffer. Are we together? Okay. Now let's go to the protocols that has to be followed. The first protocol will be looking at what? The pre-shift preparation. And what does it say? Atherian, what does the pre-shift preparation say?
Review the patient record, care plan, and any recent updates. Check for any pending task or than the previous shift. Maintain privacy, prepare quiet and private place next to the patient. The patient need to be present.
Okay. Now, with the protocols, you read the protocols when I am done, because that is just not. Let's go to the report itself. So we don't make any error. Ma'am, Aisha will take me out of this class immediately after. Now, when we go to our admission endorsement, admission endorsement starts with what and ends with what?
Complete was start with diagnosis, medication, allergic reactions, and medications.
Admission report starts with what and ends with what? Remember, I'm still considering the fact that you read before.
Start with the title.
Now, the first thing we're looking at an admission report is its date, the title itself. You must write the title of your report. Without a title, it means nothing. Now, you have an admission report. Which is the first thing, is a title. Number two, we have all these reports, so I'll take the others because it was just going to be a breakdown of all. Number two, what do we go from there? From the admission report, we are looking at identification of the nurse. Who is the nurse? Your admission report, it says that admission report, you have the date of admission. When was the admission? The 5th of the 5th month 2025, or the 6th of the 6th month 2025, or the 7th of the 7th month 2025. You write the date of that admission. From the date of that admission, you identify yourself. Are we together? So it starts with A, the title. It goes to B, the date. It goes to C, she has already declared. All right. We have the dates, we have the admission, we have the identification of the nurse. We need to know who is talking. Okay? If we do not know who is talking, I'm going to send one admission report to, we have Ivy, Kalpana, Miriam, Bacteria, Bowen Short. Absent uniforms. Okay? Now we'll have the identification of the nurse. And the identification of the nurse will start with her name, where she's from, Nurse for Home Healthcare, the date of that day, and the shift, the shifting hours. Is it 7? Is it 8? Is it 9? Is it 10? Is it which shift? When we leave from the identification of the nurse, we'll be looking at the patient's identification. So 1, 2, 3, 4. We have patient's identification. And from the patient's identification, we'll be looking at what? The patient's name, the date of birth, the age stroke sex, category, health card number, home address, and care partner. Who is your care partner? Now from there we'll be going to what?
Medical history.
The medical history. You indicate all what the patient has been is from as per the diagnosis. Okay? Now when you are done indicating what the patient is suffering from as per diagnosis, you will go to what? The allergies. You indicate if the patient had any recent allergy. If it is a yes, you indicate what allergy it is. If it is a no, you will say no. From there, we will be looking at contractions. Is the patient on a Foley catheter, a stoma, a urostomy, whatever, a tracheostomy, anything that the patient is on, you should indicate that the patient is on it. Next, we'll be looking at the medication. Now, this is where there will be a difference between the admission report and your daily report or incident report or any other report. The medication. Now, for the admission report, you are listing all the medications that is on your medication list with correspondence to the route and the frequency. Are you understanding? You just list 1, 2, 3, 4, 5, 6, right to the last one. But in a situation or in a scenario where you have all this medication listed, whether you're working morning shift or you're working night shift, you should list it. I want to see it. Now in daily report, you are not listing the medication. In incident report, you are not daily stroke incident report, you are not listing. Daily stroke admission report or hospital appointment, you are not listing. You are telling me which medication you administer at what time. So under medication, you have 8 o'clock, the medication you administer. You have 9 o'clock, the medication you administer. You have 10. If you do not administer any medication at all, then you don't write any medication. If you are working a night shift where you don't have the opportunity to administer this medication, it is okay if you keep the medication list, because at least we will know that the patient is on this medication, even though you are not the one administering them. But if you have one of that medication that you administer, you can equally keep the list, and in your intervention, you write that one medication on the hour where you were given. You can still be working night shift and have few medication, and you decide not to keep the medication list. You just write 8 o'clock or 7 o'clock, you write the 2 medication that you are administering. I will accept it. Is that understood? Is there any need for any more explanation with regards to this? Now, if we leave our medication, we'll be going to assessment. And for your assessment, number 6, we have assessment. For your assessment, it will be the same. Okay? You need to assess your patient, respect the ABCs and head to toe. You do all the assessment and you write it. Now, when I put you girls into the senior nurses group, you will see that they are not writing assessment. They are just reviewing patient is stable and you write vitals. It is not for you to go and write patient is stable and you write vitals. Because they already work with that patient for a long time. They know the patient, they understand every scenario, and I understand every scenario of this patient. And now I know the patient is stable. However, if any of them have a situation where the patient is having fever, is admitted, is has a fall, patient has one crisis or the other, they must put the full assessment. So if there is anything that changes, you must give me the full assessment. If nothing changes, you will write only patient, they will write only patient is stable. There will be a time where I will relieve you from where you will do all the assessment or write all the assessment. That time will come after I know that you have understood your patient and I too know this patient good and well enough. Is that understood? So you will see others that are doing the full assessment and writing the full assessment, and you see others that are not writing the full assessment, do not go to copy it, because we nurses like shortcut. Is that understood? Okay. So when we finish with our assessment, we already have a breakdown of the assessment you're going to do, so I do not need to take you through that. From the assessment, you're going to what? A care plan. And your care plan, you should tell me what and what and what is the care plan for that day. You keep it short, you keep it simple, and you go straight to the point. From your care plan, you tell me your goals. Every nurse has a short-term goal that they should execute in a particular day. Apart from the long-term goals that you have a short-term goal that you must put all of these together to attain or to achieve that long-term goal. From your goals, we'll go to interventions. And your interventions will start with when you receive or how you receive your patient, and end with how you handle over. And in between that is what you did for that whole day. At 5, you give medication. Now you don't need to now put the medication that you gave at 5. If on that medication you had already listed, you just need to put at 5, you said medication administered. Now I know the medication you had administered already because you listed it up. Is that understood? Okay. When we get to this level, this is when appointment report, incident report will come in. This is when appointment report will come in. This is equally when maybe the end of life report will come in. Is that understood? So you came in the morning and you respected all these rules and regulations by say 11:008, patient fell. So your heading will say at the daily report stroke incident report. But the incident happened at what time? At 11. So it is at 11 that you are going to explain to me all the incident. If you went to the hospital by 11 and your daily report show appointment, it is at 11 that you explain to me how you went to the hospital. And you end the report with who you handed over to and how was the patient. Is that understood? And again, under assessment, your vitals should always be in one position. So I want to see you say assessment, you say BPH, this, and then you do your assessment. Don't go to circulation and put me blood pressure, and then you go to disability and put me level of consciousness. That will give me a lot of work. If there are 50 of you, I do 50 daily report. But you are doing only one report, so help me. Don't give me much work that I don't need. Because I will read through, but my eyes will go through first to the vitals, and if the vitals are stable, I know that your patient is stable. Now, from the interventions, we are going to what? Appointments. Okay? So assessment, we have 7, we have interventions. From the interventions, we will now be going to appointment. Now this position for appointment is you to give me a future appointment, not for you to tell me the appointment that happened today. So if there is a future appointment, you tell me when. If there is no appointment, you tell me no appointment. From there, you go to your nurse's note. Now, do you see where your nurse's note has come in here? Your nurse's note is just to tell me few things, not everything. Mostly, after reading your report, what I'm taking to make my own report is only your nurse's note and your vitals. And sometimes recommendation if it is important. This is what I deduce from your report to make my report. Now, your nurse's note is simply what happened different that day, not what happened every day. If your patient is okay, healthy, good, stable, you just need to tell me here, patient is stable. All vitals are within normal range, period. And you go to your recommendation, Because after nursing law, the last thing you have is recommendations. You go to your recommendation, continue with care and treatment. That is all. So if your patient is completely healthy, good and fine, you just need to tell me vitals are within normal range and recommendation continue with care and treatment. You don't come and tell me continue with vitals, tell patient, do this. The nurse already knows that that's what she's supposed to do. That is why she's a nurse. Now, if something actually happened, there was a fall, there was an appointment. If you do not want to put that fall and appointment in your interventions, you can write it under your nurse's note. But do not write it on the tool. Choose where you want to write it. If you choose to write it within that time intervals, no problem. Here you just need to indicate that patient fell. What happened after that? But if you don't want to put in interventions here, you can give me the full story of what happened and your interventions to it. No problem. Let's say patient had a high blood sugar and get a crisis. You tell me that the patient had a high blood sugar and went into crisis. The last time, before handing over, the patient's blood sugar was 300 milligrams per deciliter. And under your recommendation, you are recommending that the next nurse to check the blood pressure, the sugar level after 2 hours, after 3 hours. That is a recommendation. You are not telling her to check mama for risk for fall. That is a recommendation. Now, this recommendation is just coming from everything? No, it's coming from a particular thing that happened this day. Let's say mama has been agitated because she went to the hospital. You indicate the patient is irritable and has been agitating since you came back from the hospital. The next, approach with care. If she goes there now and be all joyous and be all provocative and mama shoot her with a bottle, do you think that she's coming to tell me that mama was violent? You provoked her. Because even your previous nurse told you that you should approach the patient with care. So have you seen that I have taken just one explanation and explained all the 4 different reports? This is how you present your report. Presentation of report as nurses, we are not just taking and doing the call that the Lord has sent us to do. We are equally making sure that while at it, we do not go to jail. If you were a hairdresser, or you are a salonist, or there's surely the same people, or a tailor, or a fashion designer, or a furniture maker, if you make an error, you go to the market, you buy more product, thread, materials, and you do it again. No harm cost. The only thing is you might have financial losses. We as nurses, if we make an error, a patient might be in crisis. A patient might be hanging their life on life or death. A patient might die in a situation that is severe. And you will be questioned. You will be sent to jail. You might lose your life in it. Is that understood? So you tread with caution. You do the right thing at all times. And then you can go home and rest. When you were receiving the call to be a nurse, did you see me there? I equally received mine, and I was a nurse. And you received yours, and you were a nurse. This is what we choose to do. We were not forced to do it. And even if you were forced, you had plenty of opportunity to refuse and come out. You decide to do it, and you are still doing it. So shall it be. The only option we have to do is care for our patient holistically in the best way possible. Am I saying that you cannot have scenarios where you might be assaulted? There might be. Immediately any of that scenario ever happen, call immediately and you'll be sent out of that house immediately. Is that understood? No sexual harassment, No verbal harassment, no assault, nothing. No physical harassment. If you receive any of that, report immediately and you will be taken out of that family. Is that understood? As much as you are not going to neglect a patient, you are not going to insult a patient, you are not going to assault a patient physically, emotionally, or financially, any way possible, you are not permitted to do that. Any aspect of negligence or of assault, you will be investigated upon. Is that understood? I always say the best way to care for your patient is caring for them in the same way you will care for your own parent. It's knowing that as you are here in Qatar taking care of somebody's mother, somebody's child, somebody's husband, somebody's father, your own family is in the Philippines, in India, in Africa, that another person is caring for. Because the best revenge that we will have as nurses is have another careless nurse take care of our patient in a careless way. Then you can feel the impact of what it is to be a good nurse. Is that understood? So I am trusting that tomorrow will be the beginning of your really new journey. Do not be afraid of the communication. There will always be communication problems. Whether you travel to which area of the world, except you're working in your home country. And even in your home country, how many different languages do you have? We have more than 220 or 40 something. So even if I move to one town, I'll still have problems with communication with one mama or one baba that does not understand English. Now to us, it's not just the dialect, we have French or English to worry about. So you just go with an open mind, you learn what you can learn when it comes to language, and it will be good enough to take care of your patient. A nurse has just one language, and that one language is love, empathy, and compassion. Is that understood?
Yes, ma'am.
This marks the end of your class. Any question? Any doubt? Any clarification? Again, as you go home, make sure you are prepared, well prepared for this. Okay? And always keep warm when you're in the house. Do not expose yourself in having cold, because with cold you either cannot go to work. Keep warm and make sure that everything is okay. For the senior nurses, you will be having your patients as soon as every other documentation is okay. You just be patient. I know it's not easy sitting here while waiting, but it will be over with no time. Okay? All right. For them, no. For you, yes. Until when you receive your patient. No, you are going to work tomorrow. Today is your last day in class. That is the PMIs you are going to use for your shadow. And you are not keeping it in the patient's house because the primary nurse already has with her. We don't want confusion in papers. You go to work with your PMIs and you go back home with your PMIs. The first week you already know who you're working with, and the second week you know who you're working with. I'll only call you back on Saturday for your case scenario. Is that understood? Okay. I hope that you manage your case and show a very good example.
Thank you, ma'am.
You're welcome.